thank you for joining us. And I would like now to give the floor to Dr. Joseph Linai. Dr. Joseph Linai from the Ministry of Health in Kenya. He's the Director of the Health Sector Coordination, Intergovernmental Relations and International Health Relations. He's a medical doctor, a public health specialist and public administrator. He holds a Bachelor of Medicine and Surgery, Masters in Public Health, Masters of Business Administration and Strategic Management. He has more than 15 years experience in healthcare management. Mr. Linai, please, up to you.
Thank you, Walid. I really want to appreciate. And without wasting much time, I would like to go into my presentation. My happiness is that I'm addressing medics or people who have gone through the indications of Caesarean section and what can be done and what could be causing this. So let's start with the first slide. Next. You have the clicker just in front of you. Thank you. So we are looking at improving maternal health, and the Kenyan context is that when you look at Kenya and there's no light. When you look at Kenya, the green shows most of the arable or good place where farming can happen, and there are rains. But you see Kenya, almost 3/4 is actually dry and semi-arid. And what you realize is that the place which is really faced with a lot of challenges when it comes to maternal, neonatal, and even child health indicators is actually that place that you are saying is arid or semi-arid. And I'm happy Makueni is actually a good example of that. So, why is Caesarean section necessary? Of course, we do know. And I'm happy I'm talking to medics or colleagues who have been in the health sector for quite some time. And we do know there are two types of Caesarean sections. Of course, the elective and also the emergency. All of us do know the famous 3 Ps that make us to make that decision. Of course, if there are issues with the passage or the passenger and even the power, the maternal power, they do end up making us to think of or really say that we need to do a Caesarean section. But of course, in terms of elective, these are the causes of or indications for Caesarean section, breech presentation, other malpresentations, twin pregnancy, maternal medical conditions like cardiomyopathy, where the labor would be endangering the health of the mother, and fetal compromise, and transmissible disease like poorly controlled HIV. Others are primary genital herpes, especially in the 3rd trimester, where we need to take precautions so that it is not transmitted to the baby. Placenta previa, we do know about the 4 grades, which is an indication. Maternal diabetes leading to a big baby. And previous major shoulder dystocia, previous 3rd or 4th degree perineal tear, and even some things like maternal request. Sometimes the mother may request that she would like to have Caesarean section for this pregnancy. Okay. It's really going. Sorry about that. Apologies for that. Sure. Yeah. Yeah. What about emergency Caesarean sections? What are some of the indications? Back there. Emergency. Yes, there. What are some of the indications for emergency Caesarean section? Fetal or maternal distress, prolapsed cord, and this is where the umbilical cord drops into the cervix, from the cervix into the vagina, ahead of the baby's head, and maternal hemorrhage and placenta abruption, where we have the placenta detaches prematurely from the wall of the uterus, sometimes also uterine rupture. Of course, it's important we do Caesarean section when we have uterine rupture. Next. So having gone through that, the indications and why we do Caesarean section, and this is cross-cutting in every setup. What are some of the challenges of providing Caesarean section in low-resource settings? First of all, which resources are we talking about? Where we have constraints in finance, either in the system or even the person himself or herself, the family not being able to pay for the Caesarean section, and also some human resources. We need to look at that, and also infrastructural. Human resources, of course, very important on the issue of the mix that we are talking about. You may have a surgeon or a gynecologist or an obstetrician, but if you don't have an anesthetist, if you don't have a theater nurse, if you don't have even the cleaners, we look at even the support staff in any setting, they will always pose a challenge. What about infrastructure? Yes, you may be having a facility, but at the end of the day, maybe you don't have some equipment or so. So in a nutshell, that is what we are going to look at. And some of the challenges of providing CAs, of course, are caused by the delays. And these delays, we look at the lack of knowledge, which is usually the first delay, by the mother herself or even the family or the household. That they need really to take precaution and even visit a hospital. So that is one of the challenges that comes therein. Lack of logistical infrastructure, where we have distance away from where the CS section services are available. Then, as I said earlier on, the other challenge is about not having the right mix of human resource to do this Caesarean section. And it is, of course, usually a teamwork, and equipment, including negligence sometimes, and thank you. So the take-home message is actually that we need to have deliberate effort to ensure that there is equity and equality in terms of addressing maternal health issues. Deliberate.
Thank you very much. Apologies for the technical problems. Now I would like to present Ms. Petra ten Hoop Bender. I hope I spell it correctly. She's the technical advisor for sexual and reproductive health and rights at the UNFPA Office of Geneva. She's a midwife, former Secretary General of the International Confederation of Midwives, former Executive Officer of the Partnership for Maternal, Newborn and Child Health, and Director of the Dual Career and Staff Mobility Program at the United Nations. She published a number of papers on midwifery and international health policy. Please. You may potentially say next so they can organize from the technical.
Thank you very much, and thank you very much for giving me the honor of being here to talk to you today. I'm going to talk about Caesarean sections, but I would like to talk a little bit about respectful care before we go into that, because I think it's something that really kind of is important to continue and carry on into the area of caesarean sections. Could I have the next slide, please? And the next one. Thank you. So, what do women want? They want a safe environment, they want to feel supported when they are going into pregnancy and childbirth, they want to be able to be participating in the decisions that are made by and around and for and with them. And those things all together really make a more positive birth experience. And a birth experience that is positive makes that they are stronger when they start as mothers, that they have a set of tools that come from themselves intrinsically. And women who are who value being provided that care are also more able to speak up for themselves and their families going forward. So these are findings from one of the WHO reviews on the standards of improving quality of maternal newborn care in health facilities. They date to 2016, they've been updated, and they have been reviewed by others in various ways. Next slide, please. So it all starts, as I said, with respectful maternity care. So that goes around being free from harm and mistreatment, maintaining privacy and confidentiality, preserving women's dignity, and a proactive provision of information and seeking of informed consent. Again, something that's important with regard to caesarean sections. And of course, ensuring continuous access to family and community support. Things that are not new to us, but things that we do in the rush of having to go for a caesarean section tend to forget. So, the respectful and inclusive care is a key element of providing quality maternity care. And there are many new pieces of evidence that are coming around showing that the importance of the connection with the care provider, the inclusion in the discussions, and the opportunity to actually understand what really is happening and how things are progressing, which I know is very difficult in an emergent caesarean section situation. But women who we've talked to and who we've been asking how care is going and how it has been, have found that there has been a lack of privacy, that they have had a lack of supportive attendance, and that the fear of being cut or forced to have a caesarean section is very large, is enormous, hence that maternity care that needs to be supportive and explicative. Being shouted out, for example, or insulted, or even physically abused during labor or after birth. Some women even experience a caesarean section as abuse. And, you know, again, having explained how those things have to happen and go, makes it important to really take time to do that properly. Healthcare providers have been rude, for example, and bossy. I mean, these are all things that we all know. But being left alone during labor, or giving birth in a facility without the presence of a healthcare provider or without someone from your family, or having full communication and information about your situation really makes things different. Next slide, please. So do women really prefer a caesarean section? And given the information and the research that has been done, there are some women who really do prefer a caesarean section and who want to kind of get rid of everything that might have to happen and just like, you know, I want to be sure it's going to be this day, it's going to be this way. But there's mainly the reasons why, or many of the reasons why women go for that is because they're so worried and they don't know how to deal with the pain, with the injuries, what's going to happen with the child during labor, and they really are uncertain about vaginal birth. And they see lots of advantages in caesarean section. But there are also many women who had a clear preference for vaginal birth in the research that was developed by WHO. And those who even developed strategies to keep their birth plans in environments that were not supportive. So they wanted to keep to the plan that they'd made and how they developed their thinking when they were not supportive, in places where vaginal births were not supported. And findings also indicated that social, cultural, and personal factors, as well as attributes related to health systems, impact on the reasons underlying women's preferences for various modes of birth. So again, notes to us, notes to people who are running health systems, that it's important to give the opportunity for women to have a discussion and to talk and think about things that might be happening to them. So what can healthcare providers do? Honour the definition of respectful care, as we've just shared with you. Discuss how birthing facilities work, what it means, what the relationship is between the woman and her facility. Learn together with colleagues around in the facility from settings about the overall approach, how the facility is set up, and how evaluation of performance can really improve the quality of maternity care. But also set up groups with women and families who can then discuss their situation and even, for example, look at other opportunities for providing care or backup that are not dependent on the health system, which is oftentimes so overworked. Ask women to contribute their experience, listen to what they're talking about, listen to what their perspectives are, and make sure that there is enough flexibility among staff and respect for women's wishes and needs during pregnancy, childbirth, and postpartum in a way that doesn't disrupt the methodology or doesn't disrupt the working in the various areas of the health system. So in this time of COVID, the one other thing I wanted to talk about is how important it is for healthcare providers to look after their own mental health. These are times of stress. Some places it's kind of alleviating a little bit, but in other places it's not. Our work environments are high risk, extreme pressures, there are shortages of equipment in many places, lack of ability to spend time with the family, and there's also oftentimes a serious threat to the mental health of those saving lives amidst a crisis already as it might be in the case of a C-section, but also in the context of COVID. And in many countries, new psychosocial support services for healthcare providers have been established, such as in Bangladesh, where UNFPA supported the establishment of anonymous hotlines and face-to-face counselling. So I'll leave it there, if that's okay, and look forward to the discussion.
Thank you very much for your presentation. Thank you. Now we are going to have a short movie, 10 minutes movie, before proceeding with the other presentations. Good.
So in Kenya, we've made quite some strides in the area of Caesarean section. There's been a lot of programming that have focused especially on access, but now the challenge that remained was the issue around quality.
As a county, we perform about 4,000 Caesarean sections in a year. Natural birth is usually preferred, but in as much as they have complications, there are patients who really need Caesarean sections, and if they are not performed, then we end up with a bad outcome. Of the mothers that died in 2020, about 70% of those mothers had had a Caesarean section. As a county, we are only 3 obstetrician gynecologists, and we have 9 facilities. So only 2 of those facilities are being managed by obstetrician gynecologists. So the other 7 are manned by medical officers. And medical officers are junior colleagues in the training. They have not specialized in obstetrics and gynecology. So there's a dire need to train these medical officers to be able to do the procedure the right way and to prevent complications and then to be able to manage complications in case they arise.
Makueni County is on the southeastern part of the country. A very good community that is hospitable and kind. And as Jhpiego, we like to work in Makueni because it's one of the counties that we already have investment through other programs.
My name is Mary Mudengi. I'm a technical officer. Currently, I'm working as a technical officer for Obstetrics Safe Surgery funded by Johnson & Johnson. The aim of the program is to improve access to safe obstetrical, surgical care and anesthesia care in Kenya.
I would say the first time Obstetrics Safe Surgery came to Kenya was in 2018, but really WHO was the main prompt. Jhpiego at the global level was able to pick up that and start focusing on it.
There was no curriculum for obstetric safe surgery in Kenya. So we had to go down and involve all the stakeholders. We had the Department of Reproductive and Maternal Services involved in this. We had Kenyan Society of Anaesthesiologists. We had Kenyatta National Hospital. We had training institutions, and we had Makueni County representatives who came on board, and also the Kenya Obstetrical and Gynecology Society, who had to come and validate the curriculum for the country.
Now you need to understand that in Kenya we have like 225 physicians. We are talking about a population of 50 million, okay? Globally, WHO recommends that 1 physician to 1,000 patients, or rather 1,000 people. So that is a ratio of 1 physician to 222,000 patients. It's not possible. So for us to make sure, as Kenyan Society of Anaesthesiologists, to make sure that we offer quality and safe anesthesia to every Kenyan, yeah? So we come in to fill in the gap by giving education, trainings, and workshops to the non-physicians. And actually that is why this course, this training is very important.
Actually, obstetric safe surgery is the best program so far, because before we were not keen on training the surgical teams, especially the anesthesia care, which has been lacking in Kenyan systems, and the teamwork which was there in theaters. So for obstetric safe surgery, we have taken care of the team cohesiveness, which is very key in care of patients and safety.
Actually, when we were in college, there was a joke we used to make at anesthetists are the unsung heroes. Actually, in theater, we are the drivers. Surgery cannot start if the patient is not under anesthesia.
Initially, this is a very highly specialized area that had been just left to the obstetrician and anesthetist in theater. The two work very independently, and bringing these two teams together and telling them that, you know, they have to work together was quite a challenge. Some people also thought having a team-based approach to this training of obstetric safe surgery was a challenge. But we were able to bring all these teams together and agree and come up with a curriculum that serves to train these providers in a more holistic way, which is team-based.
I've been working in this mother-child now for 7 years. Professionally, I've been in the profession for 32 years.
Good morning.
This ward is where we keep our post-Caesarean section mothers. They are taken care of, they are given IV fluids, they are given their treatment. We counsel them on self-care, breastfeeding, family planning, so that at least they space the babies. They don't come back after 1 year. A group of people, the doctors, Dr. Mbidi and medical officers and the anesthetists, they went for a training, and then they were trained, then they come and briefed us.
So one of the unique things about the obstetric safe surgery training is that it's more of a skills-based training, where we do more of practicals. We actually have very few lectures and very short lectures, but the practicals are what occupies the day. When the teams practice on the mannequins and they are not in a hurry, you know, when you're doing it on a real life, you have to be in a hurry because you're saving life. So when they're practicing it, they are relaxed. We correct them as they go on. So, and then we are able to get them have the right skill before they can actually go back to the facilities and practice it. Yeah, so in the training, there were many new things that we learned that we are going to come and implement. One was the use of the WHO surgical safety checklist. So that is a checklist that has been in existence, but as a facility and as a county, we are not using it.
Okay, my name is Maureen Lezeni. I'll be operating a surgical safety checklist for now. Sterility of equipments? Yes, sir. Confirmed, eh? Anesthesia machine check? Done. Okay. Pulse oximeter of the patient? Yes. Saturating at? 95%.
The vaginal cleansing was something that we were not doing before. The prevention of infections following surgery, we were able to implement the proper use of the antibiotic prophylaxis that we give. Then immediate initiation of breastfeeding and skin-to-skin contact after the baby is born. That never used to happen in our theaters. Yeah, then the other thing is, was about surgical site infections and tracking. We were informed that we should track these patients for after 7 days and after 30 days because most of those infections happen in the community after discharge.
Nasema si kuongopa juu nilikuwa nataka mtoto. Juu nilikuwa nimepoteza wangapi? 3. Sasa nikasema chenye nitaambiwa na daktari ndicho nitakubali. Juu sasa nikipoteza mtoto mwingine wa 4, sasa sitakuwa na raha. So si kuongopa. Ni kitu muhimu sana Milka na Karo na daktari kukuja kuniona juu kuna vyenye naweza misuse kidonda. Wanakuja wananiambia vyenye napaswa kutunza kidonda isiingie maji, vyenye kitovu ya mtoto napaswa kuipanguza. Yani ni wazuri.
You know, they say learning is a continuous process. Until you go back to class, that's when you will learn that, oh, I've been doing this and this is the way it's supposed to be done. Now, the training opens up our mind in one way or the other.
The rates of Caesarean sections are increasing. As a country, we are not able to put an obstetrician gynecologist whenever there is a theatre for Caesarean sections. Most of the trainings that we have is you train in school, you do an internship of like 1 year, and then now you're released to go and practice. And most times you are like the medical officer in a small facility and you are on your own. So it's very important that we target these medical officers, train them and refine their skills as they continue practicing in those facilities.
Ultimately, this project is a win-win situation. We get a happy mother who has a live and well baby, but more importantly, the community will be celebrating that she's safe, she's fine. We know that the mothers are really the backbone for any communities, and we need them to get out of the surgery safe and alive.
Makueni is a pilot county. We are very pleased to say that there has been documented progress in our program implementation. And by the end of it all, we are very sure that the country will take it up. The county has taken it up because they supported even 1 extra class. We have trained 29 healthcare providers for that.
They say knowledge is power. I'm powerful.
Have the evidence about this. This is Dr. Daisy Ruto, who is the project lead for the Obstetrics Safe Surgery Kenya project by Jhpiego, and an affiliate of Johns Hopkins University, responsible for providing overall strategic guidance and technical advice for the implementation of the Kenya Obstetrics Safe Surgery Programme. She also leads the implementation of the obstetric fistula and SMILES for mothers PPH projects in Kenya. Daisy holds a master's in obstetrics gynecology and has experience working in the public, private, and NGO sectors. Please. It may work. You have to point out the
Thank you very much, Walid, and I appreciate the opportunity to be able to share with you about the work that we do in Makueni County. The film was a perfect segue for me to speak about that work which we do. Next. So why do we emphasize on obstetric safe surgery, or why are we even implementing this program? And Dr. Walid has touched on this, that having timely safe CS can avert maternal deaths about 25 to 30% every year. And we also do know that African mothers have 50 more times more chance to die compared to the high-income countries. We also know that WHO does say that there is an optimal rate of cesarean section, which is about 10 to 15% at population level. And what we strive to do with this project is to ensure that we are close to that WHO recommendation as much as possible, avoid doing cesarean sections too early or too late. We really want to avoid a lot of underuse as well as overuse. And this is a challenge that we do find in Kenya, not unique, with the private sectors having cesarean section rates going up to 50% or even more. And sometimes for our public sector, we find facilities that go below the 10% acceptable level for WHO. So in Kenya in 2018, results from a confidential inquiry into maternal deaths was released, and it showed that maternal deaths in Kenya is largely due to workforce related factors, and I single out the 30% inadequate clinical skills as one of those factors. Majority of the deaths occurred during the cesarean section, about 7.8%. And when those deaths occurred, they were really being managed by the medical officers. Not to say that they did cause the death, but most of the time we don't find any obstetrician in the facility, and the cadre of staff that we find there to perform the cesarean section is the medical officers. So it is important that we really train those medical officers to ensure that they do the right procedures and improve the survival for these mothers. Of course, we are not training them alone. We train them together with their entire surgical teams. For us, it's important that the right procedure is done to the right person by the right time and by the right team. So for this project, Obstetrics Safe Surgery Project in Kenya, it's the only project that is addressing issues around safety in cesarean section. We started in August 2020 in a county that is highlighted in red in the southeastern part of the country. We are funded by Johnson & Johnson Foundation, and the aim really is to support the government of Kenya to reduce maternal and neonatal mortality and morbidity by improving that access to safe, quality, timely obstetrical, surgical, and anesthesia care. We are a consortium of two partners, Jhpiego and WFSA. We had an initial startup of the project in 5 sites. These are the implementing sites, but we've later scaled up to 5 more additional sites. Of course, we do have oversight from the national level, specifically the Division of the Reproductive and Maternal Health. So in terms of the program scope, we sought to build that national and county level advocacy capacity for obstetric safe surgery. Of course, we We want to have advocacy so that surgical services are improved, both all the way from the national level to the county level. But what we also did at the county level was to build clinical safety, clinical patient safety and leadership capacity of those surgical teams. And we were able to use a team-based approach. The leadership program was mainly to assist these surgical providers to demand for better accountability of the services, more resources by the county government to be able to provide safe and quality cesarean section. We also were able to strengthen referral system. We do use a hub and spoke approach, so many times the other smaller facilities that have to refer clients to the larger facilities, and part of the process was for us to strengthen that referral system between the BMONC and the CMONC sites. And then, of course, as a project, we are generating a lot of data, and we were strengthening that use by this facility so that they are able to make informed decisions to improve the services within their facilities. As a project, we had a community component where we tracked these mothers after cesarean section into the community, and we were able to talk to them on day 7 and on day 30 after that procedure, just to find out if they had any challenges and needed referral back to the facilities for treatment. So this is just a summary of our intervention package. I've talked about the clinical training. We started with the development of the curriculum. We were able to train trainers of trainers and trained the surgical teams. And we followed this by a robust mentorship program where these trained mentees were followed up over a duration of time to ensure that there was competence in the work they were doing. And I also mentioned that we did have a leadership training just for them to be able to advocate to get more resources and more accountability in terms of the services they provide from the county. For data management, for this county and even for the national level, some tools didn't exist, and we were able to work with the county, develop some registers, improve existing registers like the operation theater register to include some of the indicators which we are tracking not traditionally tracked. And then these facilities then would be able to meet on a monthly basis, review the data they've collected, and also put in plans to improve the services within the facility. We were able to provide training aids, I think from the film you've been able to see. Those are CS simulators, which we use in a classroom setup before we go to a clinical area and use the live clients. Also, we were able to support these facilities by providing cesarean section sets. For the community intervention, we trained providers how to track these clients on day 7 and on day 8. But also, we were not able to get all the mothers through the phone tracing. And we were able to train the community health volunteers who really are the gatekeepers of their communities. They are able to reach these mothers, trace them physically to their homes, and interact with them and ensure that they are doing well. And for those who had any challenges, were referred back to the facilities. We developed client literacy materials in the form of posters that really dwelt on issues around self-care, but was also able to teach the mother what the danger signs were post-cesarean, so that they were able to quickly get back to the facility for support in case of any challenges. Of course, for this county, we want these services to continue beyond the end of the project, so we worked with the county to be able to develop a costed implementation plan for obstetric safe surgery so that funding is actually set aside for these services to continue. So these are some of the areas that we focused on during the clinical training. This was a training that really emphasized on teamwork and communication, shared decision-making, of course, with the client, their families, all the staff. So it's not just the doctor deciding this is the cesarean section. The mother has to go to theater. She doesn't know why. So there's part of this training was to really ensure that the providers are taking time, talking to the mothers, and collectively as a team making the decision for this cesarean section. And then, of course, what was big for us was standardizing the skills for both the surgeons as well as the anesthetists. So that's the example of the learning resource package which we developed. And as we just heard from the film, we were able to do this with the national level. The professional societies for the obstetricians, the anesthetists, the training institutions, the biggest referral facility in the county, in the country, and also in particular this Makueni County, come up with this harmonized curriculum so that we are training these people in one classroom setup and not in siloed ways as we previously done. And then that's the county implementation plan, which we are leaving behind, so that these services continue to be offered by Makueni County. We were able to, as part of that process, developing the learning resource package, have the county adapt this surgical safety checklist, of course adapted to our local context in Kenya. And happy to say that all the sites now are using this checklist. I'll be able to share some data on that. But safe to say that this has been institutionalized in all those facilities and across the whole county. And this is just an example of part of the tools we developed with them: tracking tools, theater register, referral tools. So this was data for about a year, from March 2021 to March 2022. And we can see that the average monthly surgical volume for the sites that we worked with was about 315. So over the year, over 3,000 cesarean sections were done. We've seen the surgical site infection rate, which we are tracking, not reduce, but increase from 1.1 to 4.3, which is not a bad thing, because these facilities did not track this initially, and after training them on how to identify, how to classify these infections, we've seen that rise because of good documentation. So what remains now is for us to, work and continue to reduce that infection rate. Our emergency CS rate has reduced from 96 to about 88. This speaks to the fact that there is more planning, better planning, to ensure that then there are also elective cesarean sections planned, so that not all women are just coming to the facilities as emergencies. And then the cesarean section rate has reduced from about 33.3% to about 28.6%. A modest reduction, but this is, the highest referral sites in the county. And so obviously it's really not going to improve dramatically, considering they are receiving all their clients from multiple facilities with complication, but a good achievement for this county. And then the perioperative mortality rate also reduced slightly, about 0.4 to 0.35. We had a big challenge with a lot of COVID-related cases during this period, but otherwise, when we look at the trends, that this is, slowly on a downward trend. And then for the surgical safety checklist adherence, We've seen this improved from 0, where the county was not using any surgical safety checklist, to about 96.6%. What is interesting about the surgical safety checklist is beyond the obstetric surgery, then it's also being adapted to other surgical departments, of course, with a little customization of the checklist in terms of the procedure being done, but really it's a tool that can be used by all surgeons who use theater, be it an eye surgery, be it an orthopedic surgery. There is an attempt for these facilities to use it for all their patients. I wanted to show this in a graph form just to show or to emphasize the fact that where there is no tracking being done, of course it's 0. And then immediately after the training, we see a spike because these trained providers now are able to correctly identify the complication. They are able to correctly identify the complication and they also document properly. We are still tracking this, and of course we see that it's on a downward trend because of the anesthesia providers that have been well trained. For the mothers that we are tracking on day 7 and 30, we are able to track about 80% on day 7, a bit of loss, but overall even good tracking at day 30, over 72%. And we are tracking them because we want to know if, they developed a surgical site infection, and the rate at day 7 is 3.7, and the rate at day 30 is 2.6, which are quite low compared to our baseline of 4%. So these were just a few results which I wanted to share from Makueni County, just a glimpse about the work that we do in Obstetrics Safe Surgery. Thank you.
Thank you. Thank you so much for this success story, if I may say. Now I'm going to invite Dr. Stephen Okello. He's a consultant anesthesiologist and a lecturer at Maseno University School of Medicine in Kenya. He holds a master's degrees in anesthesia and a fellowship with a subspecialization in cardiac anesthesia. He is the current president of the Kenyan Society of Anaesthesiologists and has previously served in various roles in the executive committee of the KSA for more than 10 years. Please.
Thank you very much, Professor Walid. I'm going to talk about the anesthesia component of this and ask ourselves if there are ways that we can scale up these efforts throughout the country. And I'll start by saying that you cannot have safe surgery without safe anesthesia, and I want you to remember that. And this has been a challenge through implementation of many programs that have been labeled surgical, and anesthesia has more often than not been forgotten. As a way of giving you a background of anesthesia providers in Kenya, anesthesia in Kenya is provided mainly by two cadres, that is a physician, anesthetist, or anesthesiologist, depending on your orientation, whether you're American or British. These are doctors who have undergone their basic medical education, training, bachelors of surgery and medicine, and a further at least 4 years of training in anesthesia, whereas the non-physicians undergo up to 18 months of a higher national diploma after a previous diploma either in nursing or in clinical medicine. In terms of the numbers you must have seen earlier in the film, we are looking at 225 registered physician anesthetists and 1,600 non-physician anesthetists. And I'm saying registered, so they are not necessarily in practice. Distributing that among 50 million population of Kenya, you can see where we are in terms of these numbers. As far as Caesarean sections are concerned, that is obstetric anesthesia, these are some of the challenges, not all, but some of the challenges that we face. One that has been mentioned by almost everyone in every sector is the issue of the workforce. many a time when we talk about workforce challenges, people tend to think of only the numbers. But we need to also to think about the competence of these numbers that we are creating. So we are looking at challenges in terms of their training, the numbers, as well as distribution. Of the 1,600 anesthetists that I've mentioned, most of them are in the big cities, and that leaves the villages devoid of anesthesia provision. And it reflects, if you look at our national data, in terms of mortalities and morbidities away from the big towns. Brain drain. Of course, that is brain drain. If you look at the anesthetists in Makueni, for example, 10, 15 years ago, he is alone. He has to do all the work. At some point, as Petra said, they're going to get burnout, and they either resign or look for a job elsewhere in the town. So when I talk about brain drain, it's not only from Kenya losing anesthetists and anesthesiologists to the rest of the world, but even within the country itself, we still have a lot of people moving into the big towns, primarily because they feel there are better opportunities in the cities. Clinical protocols is another of the challenges for us in anesthesia, both in terms of availability and adherence. And this is something that we started working on with the Jhpiego and see if we can develop these protocols and try to adhere with them. And the first one is the checklist that Daisy has talked about. Monitoring of our patients. There is the monitoring, physiological monitoring, radiological, as well as biochemical. So when we talk about monitoring of the patients from the anesthesia perspective, we might have this equipment, this expensive equipment in the theaters for monitoring the physiological parameters. A good number of them are actually non-functional. So the equipment is there, but it's not functional. If you get to the laboratory, the anesthetist, you might actually find it very difficult just getting clotting time or INR or platelet count, the electrolyte count. And this is information that we need in anesthesia to make some critical decisions. And these are some of the challenges that we have to contend with, especially away from the big cities. Compound that with the absence of high dependence units or intensive care units, then it becomes difficult to manage some of the critically sick patients, thus necessitating either referral or some of them just have to lose their lives, unfortunately. Availability of blood and blood products, I don't need to spend too much time on that. It's a national crisis right now in Kenya, and yet we are saying most of our mothers are dying from postpartum hemorrhage. So you are the anesthetist, the mother is bleeding, and you have no access to blood or any blood products, in addition to other drugs and supplies. And the list can go on and on and on. But so in these challenges, we also see opportunities in them. And this is the advantage we are going to take and see how we can address them. So the question is then, why scale up this program? What have we learned from this program that makes us, as anesthesiologists, as Kenyan Society of Anaesthesiologists, think that we can scale this up? SDG 3 has been mentioned by everyone. I'm not going to spend time on it again. So unlike many other trainings, this training has focused on training the whole surgical team as a team, other than the obstetricians going to the other end in Mombasa and having their training, the nurses sitting somewhere in Nairobi and having their training, and in all this mix, the anesthetist is forgotten. This time, we are able to bring all of them together, and this has ensured that the communication among the team is better. They better understand each other's perspective. They know each other by face, not just on phone. And this communication on itself helps with the decision-making quickly, rapidly, and in the right direction. The anesthetists that we met in the field have been practicing for a while, and they were able to relate to whatever we were discussing with them, with the experience that they've had, rather than just the theoretical information they had from school. And this made it more relevant, something they could identify with within their working areas. I mentioned that the non-physician anesthetists are trained up to 18 months. Remember, not all this time they are spending in training for obstetric anesthesia. It includes everything else. So the amount of time they spend in the obstetric unit is actually not so much. So that by the time they are graduating, we still have challenges in skills and maybe to some extent, knowledge as well. What we also realize from this is that because of our interactions with them through Kenyan Society of Anaesthesiologists, we've been able to offer them real-time. They can have real-time consultation with Dr. Simiu and Dr. Mwanzia, who are the primary people who started. And this has offered them mentorship as well, remotely. So anytime they have a challenge, it's easy for them to reach out and get help. And even amongst themselves, because they know each other, they can consult among each other. And this has developed confidence amongst themselves as they practice. So how can we do this? And I'm going to highlight on the role of Kenyan Society of Anaesthesiologists in this. It is within our mandate. Training is one of our mandates as a society, and our vision is that every patient should have safe anesthesia, perioperative care, critical care, and pain management. And therefore, we are going to jump into it and swim through. We already have trainers and mentors. We have a pool of that, and in case we need to scale up, we might need to increase that, as well as training equipment in the terms of mannequins and stuff. We are not so many, but we are quite pretty much well distributed across the country to be able to provide on-site supervision and support for these people, and also help with the administrative support. Our office, we have experience with managing other training programs, so we can actually be able to house this and assist in the training. Let us not forget the role of partnerships in all this. We cannot go it alone. For this case, the J&J Foundation, Jhpiego, the World Federation of Societies of Anaesthesiologists, the government of Kenya and the county governments have really come together to pull this off. So let's try as much as possible to look at the partnerships. Advocacy in terms of training, that is both quality and quantity, recruitment and retention. And then the big question in the house is the sustainability. We must have a clear, sustainable plan. And therefore, according to the KSA, the way forward would be to increase this training. We will need to more trainers, so TOT, training of trainers. We might need to bring in more training equipment so that we can have multiple trainings going on. Audits, so that we can identify the gaps and design material or trainings specifically to address these gaps, and of course, a sustainability plan. I'd like to acknowledge finally the role that these partners have played in putting this together. We don't take it for granted. And as I leave this podium, I'd like to remind you that there can be no safe surgery without safe. Even God himself.
Thank you for highlighting the role of the anesthesiologist in the team. So now the last presentation is given by Ian Walker. Ian Walker is a global lead on programs at Partnership Global Surgery, Global Public Health at Johnson & Johnson. Ian is the senior director within the Johnson & Johnson Global Public Health team and guides the company's strategy and strategic partnership in the area of global surgery. He's the chairman of Johnson & Johnson Medical Limited UK, the board of directors and the trustee of the King James IV International Association of Surgeons. Away from work, I've been told that he's a dedicated member of the Scotland's football team, Tartan Army. So please, your comment.
Well, good afternoon, everyone. It's an absolute delight to be here and a very tough act to follow in terms of the previous speeches. I was asked to talk about how this programme can be replicated and also why Johnson & Johnson started having this conversation with them. It actually goes right back to the heart of what Johnson & Johnson is all about with their credo. Some of you may not know what the Johnson & Johnson credo is, but it was written in the 1940s and talks about how we can be global citizens and work worldwide. Global public health is really about trying to deliver from the lab to the last mile to change the trajectory of health. Why were we involved in this programme? Well, I first came across the WFSA way back in about 2016, 2017, when they were successful with a grant application to the Tropical Health Education Trust in London. And through that, they put together a very, very compelling argument and a very compelling programme, which said, you cannot have safe surgery without safe anaesthesia. And that hit us between the eyeballs. So it was actually at this event, the very last WHA in 2019, that I sat down with Julian Gore-Booth, who is the CEO of the WFSA, and we started talking about what we could do in the area of safe birth and safe surgery. And what is different about this? Historically, at Johnson & Johnson Medical Devices, we have really focused on the surgeon. Sorry. That was where we worked, that was where our products were used. And then through the work with HET and through the work with WFSA, we almost had an epiphany. And through our plans in safe surgery and essential surgery, we really took a different approach, which was much more holistic. We talked about the entire OR team, not just about the surgeon and not just about the anaesthetist, but the OR nurse, and even going as far back to say, what about the facility and what about supply chain? Because you know what? An anaesthetist is only as good as the guy who orders the gas to go into the cylinder. So there's no safe surgery without a safe anaesthesiast, without a robust supply chain to make sure that the proper products are in the right place to do that surgery. So that OR team piece, and I saw from the previous presentations, that OR team piece is hugely important as we move forward to work. So what's unique about programs like this? You've seen the amazing results that the team has delivered. And when we started talking about this after the WHA in 2019, it probably took Daisy about a year to pull together, actually the actual plans to make sure it was pulled together. I'm sure you've all been involved in programs. So what do we look for? Well, you're all in this room today, taking time out from your work because you're all passionate about the subject matter. You've all got a huge amount of passion. I'm sure you would rather be doing something else, but you're here because it gets to you. But I'm sorry, I'm going to have to put a bit of a downer on that for you. Because you know what? Passion is not enough. Passion is no substitute for planning. And when we look at programs, what you saw from the program that Daisy had designed was a phenomenally well-designed program. In that, I'm not disputing Daisy's passion, because I know she has that, but it's more the planning that went behind that. Included in the program design was a huge amount of metrics and data. What is the proof of concept? What are the building blocks for success? So we can take this program and say, where can it go somewhere else? Because we have the evidence. And also to the point that was made, the importance of team and partnership. We cannot do this alone. We cannot do this at arm's length. It's hugely important that we come together as a coalition with everybody with a different role to play. So when we're looking at programs, there's three things we look for. Sustainability. Too many programs I've seen are here today and gone tomorrow. I'm looking for programs to support that have got absolute sustainability as one of the core. Scalability. We already saw in the program that it's gone further than originally planned. But where can that go at a county level, to a national level, or dare I say, even a continent level? And that transferable piece is hugely important. So the building blocks for success that were identified, how can they be taken and dropped somewhere else? The next part I want to talk about is local support. It's no mistake there are 3 Kenyans on the team here today, and that is as it should be. We cannot do this from the UK or from the US. We have to have the people working who are on the front lines of care, working in the hospitals, who are working with the local communities, and we identify all the local champions. So to the organising group who did the project, to the anaesthetists, and also to our friends at the government and the local authorities. They have an important role because they must also provide the tailwind for success. I can't stress enough that in Makueni County, that local support from the authorities, from the government, has been hugely important in providing that tailwind. And I'm sad to say that isn't oftentimes what you see around the place. So the role of Local authorities, thank you for providing that tailwind. But it's not finished here. The work is only beginning, and we will be working further with the team in Makueni County to look at obstetric fistula. I think it's important to be talking about today, because today is the International Day to End Obstetric Fistula, IDIOF Day, and we'll be working with the team in Makueni County to look at what about fistula services in Makueni County. At Johnson & Johnson, just to end, we have been absolutely delighted to be associated with this amazing programme. I just want to stress that the delivery of this programme has taken place during COVID, during the pandemic, and I think the resilience of the team on the ground to deliver this has been nothing sort of exceptional, because it wasn't just the challenges of delivering this programme, it was delivering the programme in the face of a pandemic, and I don't think that should be underestimated. So, just to finish, thank you WFSA, thank you Jhpiego, thank you everybody at Makueni County, most importantly for making it happen, an amazing partnership.
Thank you, Ian. I'm going to open the floor for discussion or questions. There are three key elements here that have been, that you mentioned: the holistic approach, the teamwork, and the partnership. And this is essential for success. So any question in the audience?
Hi everyone. Just wanted to say thank you to everybody for presenting today, and everything that Ian said and about it being an excellent project, and the partnership and working during the pandemic to make it a success. But I also just wanted to say I think the piece of communication you made, the video, is a lovely piece of advocacy for global surgery as a whole, and also that you all took the time to come here. I know it's not easy to get here and to travel, but I think it's really important to talk about success stories like this, even if they're new, if they're still underway and you still want to do more, because we don't have enough success stories, and it's really hard to do good advocacy on global surgery. So I just appreciate that you put that together as well. Thank you.
We all agree with you, I think, and this is a good example of success story, so we can make it, and I agree with you. Yes.
Hi, I'm Vedant Shukla from India. I'm a youth delegate as part of the International Federation of Medical Students Association. So I would like to ask the panelists what they think or how they think we can include young people, especially medical students, in this effort to reduce mortality and morbidity from C-sections. Thank you.
Who would like to answer? Potentially Stephen? Would you like to answer?
Thank you for your challenge. We are going to take it up. What we were thinking is, once we've shown that this can work, we intend to try to come to the basic education, because we are going to train these people to become medical officers. We can incorporate some of these workshops at the end of their internship, so that by the time they are going out to practice, they already have some basic level of skill, and then we continue to support them during their initial days as medical officers. Thank you.
Okay. Question.
First, I would like to congratulate the World Federation of Societies of Anaesthesia.
Thank you.
And also more the Kenyan government and the Kenyan team, country leadership, as well as the support from Jhpiego and Johnson & Johnson. This is the first time we are seeing something strong at the global level on maternal health. For the last 20 years, maternal health has been neglected and continues to be neglected. Today, you listen to the DG of WHO. He hardly mentioned maternal health, not to mention anesthesia or surgery. This is a great deficit in WHO. This is the same WHO in the 1990s with primary health care, out of its 7 priorities, made maternal and child health the fundamental of its work globally. And that was the period when maternal health in the 90s everywhere globally came positive with rapid reduction of maternal mortality due to district health systems driven by primary health care, supported by general medical officers in the districts, and supported by nurse anesthetists and medical officer anesthetists, but more nurse anesthetists. That made a difference. Today, with a lot of resources, we are unable to do enough on maternal health. Why? And I'll leave this question, and I'd like to thank Ian for bringing out this issue of taking this model. How can Kenya and all the partners take this model into the heart of WHO and globally? This is important because this is what the lessons of history are. So that question is, it doesn't die under the name of reproductive health or sexual health. Today I heard the DG talking many times about sexual health, but not maternal health. And sexual and reproductive health have continued to undermine. This is a global need from the North, but it's not the first priority of the South. Thank you.
Thank you for your comment. You would like to answer, to reply? No? I just, somebody would like to reply? Potentially you may reply. I mean, this is why we are doing this session, actually, to bring this, to highlight this within the WHA, somehow. So, but I agree with you. I mean, we understand. Thank you for giving this comment. There are two other questions or two comments. Yes?
There's one here.
Yes, there, first. Sorry.
Thank you so much. Also to echo the sentiments of the other people in the room saying congratulations for this amazing work. I'm Salome Maswime. I'm the chair and head of global surgery at the University of Cape Town. And my background is also in Caesarean section work, so quite excited to be here. My question is, how do you plan to expand this? You know, what we've seen with Caesarean section work, obstetric surgery work, is that it usually works as a good template for programs to expand surgical care. Primarily in our countries, we know that the same people that are operating, doing the Caesarean sections, are doing all the other surgeries as well, even though they're not necessarily trained or qualified to do them. So how do you look at expanding this in terms of surgical skills beyond obstetrics, or at least using it to dovetail on the future of your program? Thanks.
Who would like to reply? Yes.
Thank you very much for your question. Really valid question. For us in Kenya, one of the things that is a next step is to have that conversation at the national level about this curriculum. Take it through a process where all the key stakeholders sit together and then validated and adapted as a national curriculum so that it can be used across all the other counties, all the other 47 counties. The other thing that we must do is to include some of the components within the pre-service curriculums of the learning institutions, the universities, and the medical training colleges, so that as these younger doctors and clinicians graduate, then they've had exposure to some of those skills, including, things as simple as, use of the surgical safety checklist. Of course, part of the process, and I know Johnson & Johnson has supported this, is, creating those hubs which have skills labs developed for these young trainees to train during that pre-service period, even before going to their clinical areas during the internship. And then, of course, having that robust in-service curriculum where that training continues within their internship periods. Yeah, thank you.
Good afternoon, everyone. Thank you very much. I really commend the excellent presentation of every colleague in front of us. And I'm really honored to be with you. My name is Dr. Meseret Zelalem. I am the director for RMN's HD at Ministry of Health of Ethiopia. I'm really grateful to hear the experience from the Kenyan colleagues. I see this is how the government is in the driving seat and coordinating the professional associations and the partnership efforts. This is what we are also doing in our country. with a strong leadership and partnership that really matters. So for me, as an African continent, we are very far behind from the targets that we set in SDG 2030, which is the center of the SDG for me is preventing the preventable maternal mortality and morbidity. The same holds true for neonatal morbidity and mortality. We are very far behind. Perhaps 50% of the member state might be in the track, because we did have SRH, our accelerated action plan, like 3 weeks ago in Johannesburg, where we have seen like most of the African countries are far behind from the SDG target. So I was really expected such a presentation would have happened in Johannesburg, where the African issues has been discussed. The showcase, like innovative like this, would have been presented. So for me, how the Kenyan innovation or such result and recommendation can put to the table of the WHO Afro. This will be replicated in the member state, where this will definitely leverage our action or efforts towards reaching the milestones that we set for reduction of maternal mortality and neonatal mortality. So this is my recommendation. And the other thing is, I really like the word that you mentioned from the, respectful maternity care. For me, that is the center of the domain. Everyone, it's not only the midwives, or the anesthesiologist, or the anesthetist, or the OB-GYN specialists, but everyone in the care. If you put like the woman at the center of the service, for me, respectful maternity care is a core. So we have to advocate this one. Because I don't see, for example, the colleagues from the Kenyan Kenyan Obstetric and OB-GYN Society, because we have to bring every actors. We have seen even in the C-section, who are the team members. So the best has to be to bring everyone on board. I think the respectful care is the most important one. So finally, I would like to commend the result, and also this is a call to action for us, if there is any partner, to just support our effort. We have a 5-year strategy for elimination of obstetric fistula. We have also a REACH strategy, which is mainly, the domain is prevention of the preventable maternal mortality and also, of course, neonatal mortality, this will be one of the showcase. So as Ethiopian, as a country, we are very much keen to work with any partner as far as you really abide with our policy and the strategy we have. And also, I commend if the Kenyan government, the Ministry of Health, in fact, partnering with the Ministry of Health of Ethiopia, G2G, government-to-government collaboration, is pretty recommended. Thank you very much once again. Thank you, the G4 Alliance.
Thank you very much, and message well received. We're going to advocate for this, and I think you've got the Kenyan government here who can potentially take contact to implement this afterwards. But this is the role of WFSA also. The problem is also with the COVID that we had some delay, We started discussing, as Ian said, just in 2019, and all of a sudden the priority changed, unfortunately. And one of the main messages that you said, which is essential anywhere, the patient in the middle, and the patient should be in the center of all management and care, and that's for sure. So any other comment? There were some, sorry, yes, please. You wanted to.
Thank you very much. I just wanted to come back to the 2 comments that were made. Now is the place and the time to discuss and to make WHO pay attention more to maternal health. We're here now, all the countries are here now, the discussions are happening now, the numbers of people that are able to go into the meetings are limited. But I think there are many ways in which you can send the messages that you wish to go into the discussion, specifically around sexual reproductive health and maternal and newborn mortality and morbidity. They need to be heard at this World Health Assembly and picked up again at the next one and the one after that. UNFPA stands for these things as well. We speak a lot about human rights. We speak a lot about quality of care. We invest a lot in midwives, as you could have understood from my presentation. So those are all methods that help get a woman into a better condition into the facility and if needed, into a better condition when she needs clinical or medical care. Thank you.
Thank you. We just want to let the people on the Zoom, because there are many questions, just give a couple of questions coming up from the Zoom, please. And then we'll come back to the audience here. Sorry. So, can we hear the first question?
Greetings from New Zealand, everybody. My name's Wayne Morris, and I'm the President-elect of the WFSA. So thank you all very much for your talks. They were excellent. One of the points that came through to me today is that it's not just about improving the safety of caesarean sections, but it's also improving the decision-making process when we decide to do caesarean sections and not doing too many. And I'm just wondering where I'd like the thoughts of the panelists as to whether this sort of training is useful for improving that decision-making process, so that we're being more we're safer in our decision-making about when to do a caesarean section. Thank you.
Thank you, Wayne from New Zealand. It's a bit late for you. Thank you for his comment. Another comment coming from Zoom, and then I will give you the...
Yeah, thank you very much. Can you hear me?
Yes, we can.
Yes, my name is Dr. Hassan Datu Mohamed. I'm calling from Kano, Nigeria. I didn't get most of the presentation, but having joined late, what I understand, the main topic is on scaling up the workforce in anesthesia to try to stem up the maternal mortality globally. So I want to just comment that scaling of this workforce, already WFSA is doing something. I'm the technical lead of the Liberia Anesthesia Capacity Building Project. Since 2018, we've been able to, we've already produced 3 diplomates. 2 are here, 2 more are here with us in Kano. Now, the 3 diplomates in Liberia now are currently involved in the, or they've just concluded the safe obstetric course in Liberia. So what I'm trying to say is that WFSA is already doing something regionally. What we need to do is to try to get the WHO to buy this idea, and you can actually repeat this in each region. What you need to do is look at what are the programs in the training colleges. For example, for the WACS, you have 3 levels. The diplomate, which is about 12 to 18 months, and the membership, which is 3 years, and then 6 years you have the fellowship. Now the fellows will now be able to train more diplomates and membership. And this is the way to go. And then every year, in the next few years, you see that you have more physician anesthetists. Now, what will they do? There will be improvement in skills, and then they will be able to provide regular training for non-physician anesthetists existing, and also to be able to provide them effectively. Thank you very much.
Thank you very much for your comment. I think we'll have a feedback on this with Dr. Bizola. So any other, you had the question, I think. Yeah. Good question. Do we still have time?
Thank you very much. Mine will be a few comments and quickly. I know we're running out of time, and a few questions. Thank you. My name is Dr. Ahmadul Amin Samate. I happen to be a general surgeon, so I can understand Stephen's passion and so on. And we usually have a lot of quarrels in the theater, but I must tell you, they are the boss in the theater, because without them, no surgery gets done, and especially safe surgery. But we fail to agree on that. Thank you very much. I think maternal health is a big challenge for many of our developing countries. Maternal mortality is very high. And my brother here, the WR, the DG did not mention it, but if we have the opportunity, we're going to mention it during our time. Now, thank you. We have challenges, but I happen to be the health minister of the Republic of the Gambia. So, but this is my passion as well. That's why I'm here. And so I have that opportunity in my statement to mention maternal mortality and maternal health. But I think we commend you all. Because of time, I'm going to make it fast. Commend you all for your passion and your actions that go to defend your passion. But it is doable. I think we all need to understand that we have to put our minds at it. We need to train more and more people. Because most of the mortality we came to realize is because of the inexperience of the people, especially the junior doctors that we post to the provinces. They had done few cesarean sections with us in the main hospitals, and we expect them to do magic over there. So each time you have new doctors there, new medical officers, mortality tends to go up. Similarly, quite a lot of the deaths we have perioperatively are linked to anesthesia, anesthetic deaths, because the person there is not competent. So we need to train more people. I'm happy the question they asked, what are you doing to scale up the training? What we do is, when I was head of department of surgery, what I did was I spoke to the young ones during their house job. And believe me, I was able to encourage 3 of the doctors who are now specializing in anesthesia. So we need to try to put the concept in them early to emphasize the importance of anesthesia, midwifery. As a country, maternal mortality reduction is my legacy goal. So what we are doing quite a bit, we started BSc midwifery training in the university, BSc anesthesia training in the university, just because of all this. So I think we need to engage the leadership. I'm able to push this because I understand. But the engagement between the clinicians, the midwives, the anesthetists, the surgeons, the obstetricians, and the leadership, because the leadership has to look for resources. The commitment has to come from the ministries, from the administrators to get to that level. I had climbed the ladder in that order, so I know actually where the problems are. Once again, we want to thank you. But my questions are, I guess the issue is we want to scale this up because this is good for humanity. And what are we doing to scale it up in the whole of Kenya, in the whole of Africa, East Africa, in the whole of West Africa, in the whole of the world? Because it's the right thing to do. Thank you very much.
Unfortunately, we are out of time. There's the last question, and then it's over.
Okay. Thank you very much. I'd just like to add my congratulations again. My name is Isioma Okolo, and I'm an obstetrics and gynecology registrar and also a research fellow from the Program in Global Surgery and Social Change. I was really inspired by some of the tools you described and interested to learn about the referral register in terms of what aspect of that tool that you thought was the most critical in terms of successful implementation. Reason being that, similar to safe anesthesia, I absolutely think that safe referral networks are critical to safe surgery. So I'd be really grateful if you could share that. And a quick sneaky question. So we do know the WHO recommendation for, target cesarean section rates is 10 to 15%, and that is very much at the population level. There is no research that supports what the optimal cesarean section rate at facilities should be. So I'm curious, because there's a lot of discourse around how facilities and provider characteristics can impact the cesarean section rate. I was curious about your thought process as to how you would define the optimal cesarean section rate at your facilities in Makueni. Thank you very much, and congratulations again.
Do you have a quick reply?
Yeah, thank you very much for all the questions from you. I think I'll start with the last one. My thoughts about the cesarean section rate. Just to say that beyond that 10 to 15% by WHO, I think that can coexist with the extremes. We know the situation, especially for us in LMICs, that a referral site may have a higher cesarean section rate, and the farther away, the more rural a facility, smaller, might have a slightly less than 10% rate. But the idea is just to ensure that there is no overuse and also underuse. Anytime there is underuse, then the women who deserve to have a cesarean section are definitely not getting it. And most of the time when there is overuse, again, we are doing probably some unnecessary cesarean sections. And then to your question on the referral register, this is a register that aids the community health volunteers as they refer the mothers from the community into the facility. We like to track all those that have been referred through that network. And also, as they go back home and develop any of the challenges, they will still need to be referred back by the same, community health volunteer, and we're able to track that data. We support them to meet on a quarterly basis just to review all that data and also their successes around that tracking of the mothers within the community. There was one on clinical decision making. For sure, within this program, part of the training is to train those surgical teams when it comes to improving their decision making. We've trained them beyond that traditional criteria of just saying emergency or elective cesarean section. And I also mentioned that this is very much a team-based approach. So when that decision is made, the discussion happens with the mother, with her support system, and we also do emphasize within that decision making the period between the time you make the decision to the start of the surgeries to avoid any of the delays. And then, of course, even at the end of the surgery, then the whole team is sitting down to discuss even the pain management of the patient going to the ward. I think that's it.
Thank you, Daisy. Thank you very much. Please join me to thank all our speakers and the session. I mean, the discussion can continue, but outside the microphone, so if you want to have... Thank you all for coming and attending this session. I think we learned a lot.
Thank you. Well done.